Welcome to For Your Information, hosted by Congressman Mike Arcuri. For Your Information is an opportunity for upstate New Yorkers to get an inside look at the issues before Congress and learn how to access services available to you. Each month, Congressman Arcuri will be joined by a special guest for an in-depth discussion on the issues of the day or to explain how the many federal programs and services out there can work for you. And now, here's the host of For Your Information, Congressman Mike Arcuri.
Hello, I'm Congressman Mike Arcuri. Thank you for joining me today on my show, For Your Information. I want to use this show as a forum to discuss issues and topics relevant to you in the 24th Congressional District. One of the most critical parts of my job is making sure you have all the information you need about federal programs and services, from veterans benefits to getting help preparing your taxes and healthcare reform. On today's show, we are going to take the opportunity to continue our open discussion on healthcare reform. I have with me two great guests who will be able to talk about some different parts of the bill and how it will affect and benefit you at home. But before we get into today's show, I want to remind you that you can always contact me for assistance with a federal matter by calling my Utica office at 315-793-8146 or my Washington office at 202-225-3665 or by visiting my website. I have also created brand new YouTube and Facebook pages that I encourage you to visit to stay up to date with my work in Washington, D.C. and across the 24th Congressional District on your behalf. The issues for today's show are about healthcare reform. The rising cost of healthcare is straining the wallets of American families, the balance sheets of our businesses, and the long-term health of our federal budget. Millions of working Americans who want health care are not offered it through their employer and cannot afford to purchase it on their own. Right now, America spends nearly 50% more per person on health care than any other country in the world. And as premiums continue to rise an estimated 20% over the next 4 years, it is clear that Congress needs to act. On Saturday, November 7, 2009, the House passed a historic health care reform bill, H.R. 3962, the Affordable Health Care for America Act, which received bipartisan support. This bill works to provide the opportunity to purchase coverage to those who cannot do so currently and reduces the cost of health care for those that already are insured. H.R. 3962 also cuts out the waste, fraud, and abuse in the health care system, allowing hospitals to be more economically viable. In the 24th Congressional District, our hospitals operate at a net loss annually. That means they lose money each year, in large part because of the significant number of uninsured patients they treat every year. By offering an affordable health insurance option, we're making sure both the patients receive the care that they need and the hospitals in upstate New York are not saddled with more than their fair share of the cost. When I first ran for Congress in 2006, I promised my constituents, all of you, that I would work to reform our nation's healthcare system. After participating in nearly 30 public forums, including 10 town hall meetings, and speaking with countless healthcare professionals, small business owners, and concerned citizens across the district, I fought and succeeded in changing the original bill to include a number of key provisions that ultimately led me to vote in favor of the bipartisan healthcare bill, which passed the House of Representatives in November. Those include prohibiting discrimination by health insurance companies based on pre-existing conditions. No one can be denied coverage or charged outrageous rates because of past medical circumstances, allowing patients to keep their children or their dependents on their health insurance until the age of 27, capping annual out-of-pocket medical expenses, providing financial security for working families and small businesses, providing much-needed choice with a public health insurance option, competing with private insurers so that individuals, families, and small businesses without health insurance can finally afford to buy it, closing the Medicare Part D prescription drug donut loophole, and allowing Medicare to negotiate prescription drug prices to lower out-of-pocket health care costs for seniors, creating competition in the private health insurance industry to lower costs for small business owners who provide health benefits for their employees, allowing them to invest in the business and create jobs. Cutting out waste, fraud, and abuse in the Medicare, which, according to the nonpartisan Congressional Budget Office, will cut the deficit by $3 billion. creating incentives for health, wellness, and prevention programs, which will lower healthcare costs for people who choose to lead healthier lifestyles, protecting working families and small business owners by not taxing high-quality private health insurance benefits, and allowing for the sale of insurance across state lines, which will encourage competition and will ultimately reduce cost. But I want to bring in some other guests today to move the conversation forward and offer a different perspective. Today, my first guest is my good friend, Congressman Frank Pallone from the 6th District of New Jersey. Congressman Pallone is an 11-term U.S. Congressman who serves as the senior member of the House Energy and Commerce Committee and chairs its subcommittee on health. That subcommittee holds jurisdiction over Medicaid and many other federal health agencies, and also shares jurisdiction over Medicare with the House Ways and Means Committee. Congressman Pallone's experience and expertise are unmatched in this field. He was a critical voice in last month's healthcare debate in the House, working tirelessly to dispel myths and communicate to Americans what it really is we're trying to achieve through reform. Congressman Pallone, thank you very much for joining us today. And I'd like you to start by telling us a little bit about yourself and New Jersey's 6th Congressional District.
Well, thank you, Mike, for having me on the show. My district basically is along the northern part of the shore in New Jersey. It starts in New Brunswick, where Rutgers is, and then it goes down along the shore to Asbury Park and Belmar, some of the shore towns. And it's a district that's mostly small towns. In some ways, it might be similar to yours, other than it's along the water, whereas yours is inland. But
Beautiful
in terms
place.
of the size of the cities and the nature of it, we don't really have any rural areas, though. You have rural areas, which I don't have.
You represent Asbury Park as well?
Exactly.
A good, important place. A lot of Bruce Springsteen fans in
Exactly.
my district as well. Frank, I'd like to start, if we can, by talking a little bit about some of the, I think, the myths that were out there. What were you hearing the most in terms of the misinformation that was out there about the bill?
Well, I think the biggest myth that I get is people think that if they have insurance through their employer, that somehow they're going to lose it, or that if they have Medicare, that somehow they're going to not have Medicare. In other words, the one thing that we stressed from the beginning, you and I and President Obama, was that if you like your health care, you keep it. And we're not changing anything with regard to, Medicare or people who get insurance through their job, other than perhaps expanding benefits. Like, for example, under Medicare, we're providing funding to eliminate the donut hole that exists for prescription drugs right now. But we're not changing anything. We may be adding some benefits. The main benefit under this health care reform, I would say, is for individuals who have to buy insurance on their own through the individual market, or small businesses that have a small group plan. Those kinds of individual and small group plans can be very expensive, and there's a lot of discrimination based on pre-existing conditions, or women pay more than men, for example. So we're setting up this health exchange with the federal government, whereby private insurers as well as a public option are available. There's a lot of choice in that health exchange. You can buy Blue Cross, you can buy Aetna, you can buy the public option, and they will compete, and it acts like a large group plan. So it really brings down costs significantly for three reasons. First of all, now you're part of essentially a group plan. You're not buying the insurance like a small group or an individual. The competition between the insurance plans, including the public options, brings down costs. And lastly, there's a major subsidy for people depending upon their income. So we'll cover everyone, because everyone now will have access to affordable health insurance. But those who've had problems or lose their insurance can go into this health exchange and buy a cheaper policy, particularly if they're buying it on the individual market or they're a small business.
One of the points that I made throughout the debate was it's not just about the moral imperative of insuring those that don't have insurance, but the economic imperative of ensuring that people that do have insurance can continue to keep it, and that
Absolutely.
It continues to be
and
cost
even if you
effective.
get insurance on the job and you're happy with it, what if you lose your job? I mean, we're in the middle of a recession. A lot of people have lost their jobs. And if that happens in the future, when this is in effect, then you have a place to go where you can get affordable coverage.
What about the argument that I hear made on occasion about the rationing? Will this result in rationing of health care for individuals?
No. I mean, look, the reality is there's rationing of care now, because if first of all, it's hard to get insurance particularly if you have a pre-existing condition, and the private insurance companies can basically offer whatever benefits they want. I mean, we're going to have a lot of choices in this health exchange, private, public, and all kinds of options, you know, where you can have a basic benefit package, or you can have additional coverage, you know, for things that you wouldn't get now if you want to pay a little more. There's nothing in it that has the federal government in any way imposing what kind of operation or doctor you get. I mean, this is all in a marketplace where you make your choice.
A two-part question for you. One is, I'd like you to discuss a little bit about the public option, which obviously was contained in the House bill, and maybe some of your thoughts on where you think that'll be as a result of, you know, where the Senate is headed in that regard.
I mean, the public option could be compared to Medicare or Medicaid in the sense that the federal government is offering the insurance. It doesn't mean the federal government is running the healthcare system. I mean, you know, it's just another insurance option. You know, some of the opponents have branded this socialism, like they'll compare it to, say, England, where the doctors and the hospitals are owned. Well, the hospitals are owned by the government, the doctors are on salary from the government. We're just talking about an insurance option. And basically, like Medicare, it's an insurance program that's run by the government. The advantage of that is because it's nonprofit, it doesn't have to make any money other than what's kicked back to pay for benefits and health care. And so it should be a little cheaper. The Senate is probably not going to have something exactly like that. What they've been talking about instead is having nonprofit insurance companies that are run by private companies. And the federal government is involved because the Office of Personnel Management, which manages the federal employees benefit program that you and I have, would actually negotiate reimbursement rates. So it's a little more complicated. Essentially, instead of a public option, it's a nonprofit option run by private insurance. But I think it serves the same purpose in the sense that since it's not making a profit, it'll be an alternative to private insurance, and it'll be in that health marketplace as an option and create competition in the same way.
Well, now one point I think that has to be made, and I'd like you to discuss it a little bit, because, you know, obviously a lot of my constituents, I'm sure like yours, are on Medicare, and they like Medicare. And many others have Medicare Advantage, and they like their Medicare Advantage. Will anything that the House bill does affect a person's Medicare, the quality of the care that they get, or their Medicare Advantage?
Only to the extent that they'll have better benefits. I mean, one of the things we do is fill up the donut hole. Right now, if you pay out of pocket, I think, a little over $2,500 a year for your prescription drugs under Medicare, you no longer have any coverage until you get to like $6,000 out of pocket. That's the donut hole. That gets filled up, so you don't have that situation where you may
some of that happens immediately, right? I mean,
it all depends how much you spend. I mean, the average person usually hits it by September or October, but some people can hit it sooner if they spend more, or never hit it at all if they don't spend much at all on drugs. The other thing is we eliminate a lot of the co-pays for preventative care, like if you go for a mammogram screening or a prostate screening, you have a copay now. Well, you wouldn't have it anymore because we're trying to encourage people to do prevention, you know, to go see a doctor, to go have screenings done, so we don't want to charge extra for that. And the last thing, I mean, there are many other things, but the other important aspect is that we actually increase the reimbursement rate for doctors under Medicare. So I don't know where you are, but in New Jersey, a lot of doctors now are not taking Medicare because the reimbursement rate is too low. So we changed that. So, I mean, I think there's been some attention to the fact that we actually have some savings in this bill from cuts, if you will, in Medicare. But those are cuts that we've identified as wasteful, where there's been overutilization, or, you know, there's been mistakes that doctors or hospitals have
duplication
made.
Of services.
Yeah, I mean, we have to save money because ultimately, you know, as you know, Medicare is, you know, since it's a public program, you don't want it to go crazy, and we want the money to be there to pay for Medicare in the future. So we do have some savings, and they've gotten some attention, but the only cuts are in essentially reimbursement rates for hospitals and doctors where they don't do the right thing. We're actually increasing the reimbursement rate for doctors overall.
I think that's very important in districts like mine, because I hear it all the time. Doctors say that they're much less likely to take Medicare because the reimbursement rate is low.
Well, this year, if we, you know, we'll probably do some stopgap before the end of the year, but if we didn't, there'd be a 20% cut in doctors' reimbursement rates. So we're trying to not just have the stopgap where we go back and correct that every year, but have a long-term payment system for physicians. And primary care doctors will get paid a little more than even the specialists under the proposal.
You know, when we talk about cutting out waste, fraud, and abuse, everyone that you talk to is for that. But people are concerned about services, obviously their Medicare getting cut. And I say to people very often, wouldn't you prefer not to go to 2 or 3 different doctors for the same thing? Right. And if we can do it in such a way where, you know, you take blood once and you don't have to go to 3 different, and they all are very happy with that.
I know. Let me give you a perfect example. My mom passed away from pancreatic cancer almost a year ago. And I visited maybe 4 or 5 hospitals with her. And I would go and have the CAT scan done, and I would bring the film or the disc with me to the other hospital, and none of them would take it. They always made me have another CAT scan done every time she went to the hospital. And it's an invasive procedure, and she had cancer, and it was just so ridiculous. And that's the kind of thing. There's all this duplication, and it doesn't make any sense.
And that's exactly the kind of thing that I try to relate to people. But, you know, obviously, when it comes to people's health care, they are, you know, they're very protective of their health care. We have just a short time left, but I want you to just, one last point I'd like you to, people say, where is the money going to come from? How are we going to pay for this? Where's it going to come from?
Well, half of it's paid for through these savings in Medicare and Medicaid. The other half is paid for through a surcharge, if you will, on people, on a millionaire surcharge. If an individual is making over $500,000 a year, or a couple's making more than $1 million, then they pay an extra surcharge income tax. That's how the House pays for it.
Okay, and obviously that'll change somewhat when the Senate finishes their bill.
Well, the Senate has a different measure. I mean, it's hard to say exactly, you know, where we're going to go when we put the 2 bills together. I frankly prefer the income tax surcharge because I think it only affects, you know, less than 1% of the population.
Well, Congressman Pallone, I want to thank you for joining me today and helping me dispel many of the common misconceptions about this legislation. I look forward to our continued work together on healthcare reform. Thank you very much.
Mike.
Thank you. Hi, I'm Congressman Michael Arcuri. Influenza is a serious illness, and H1N1 is a serious flu. That's why the CDC recommends these simple steps to keep our communities healthy. Cough or sneeze into your sleeve or a tissue. If you're sick, stay home. Get both the H1N1 and seasonal flu vaccines. Vaccination is safe and effective. Together we can fight the flu. Learn more at flu.gov. Welcome back. My next guest today is Nora Super, Director of Federal Government Relations, Health and Long-Term Care at the AARP. As you may know, AARP is one of the leading advocacy groups for senior citizens with more than 40 million members in all 50 states. Nora, welcome, and thank you for joining me today. I want to focus on the impact of healthcare reform on our seniors and your AARP members. First of all, AARP supports the House bill?
Oh, yes, Congressman. We're very proud to endorse the House bill. It did take a while before we got to that point, but our all-volunteer board took a good, long, hard look at the House bill, and after it was passed, out of all 3 committees, we were proud to endorse the House bill.
Well, I want to sort of, so people get kind of a sense of how AARP worked with it. You didn't just agree to the bill. I mean, there was a lot of input and give and take in terms of recommendations. Tell us a little bit about some of the points that you thought were important, you know, for your organization in terms of focus.
Sure, I'd be happy to. As you mentioned, we have 40 million members in all 50 states. So with that many members, they have a lot on their minds and a lot of things that they're concerned about. And I think it's important for people to understand that about 20 million of our members are over 65, and the other 20 million are under 65. So as we looked at the bills, it was important to make sure that we were fighting for issues that helped our members who were on Medicare, and then those of our members who are 50 to 64 are often struggling to find insurance that's affordable for them. So 2 of the real key issues that we centered on were how the bill would actually strengthen Medicare for those who are on Medicare program, and so making sure that the bill closed the donut hole or the coverage gap under Part D, was a big issue for our members who are over 65, and the House bill does that. It closes the donut hole by 2019.
That surely
huge
is
issue for us.
Sure is. I mean, I have 119,000 people in my district who are on Medicare, and I know that's one of the big issues for them. So tell me a little bit about how you think that this will impact those people who are on Medicare, the present bill, because that's the big concern I get from folks at home. You know, what is this going to mean to, I'm happy with my Medicare, I'm happy with my Medicare Advantage, you know, is this going to in any way affect, you know, the quality of the care that I get now?
Well, we really think that this is going to be a big step forward for many of our members on Medicare. As you mentioned, the donut hole is something we hear from most of our members about, because more than 3 million seniors are at risk for falling into the donut hole every year. And this is when they have to take so many prescription drugs that they just can't afford to reach that point where they're still paying premiums, but they don't get anything back in return.
Can you just, for our viewers, just define what the donut hole is?
Sure. This is a place in the bill where, in the benefit where people have to pay, everyone has to pay a deductible. They pay $295, and then the government pays about 75% of the cost up until then, and most people pay 25% of the cost. And then there's something that everyone refers to as the donut hole or coverage gap, where people on Medicare are still paying their premiums, but they get nothing in return. When they reach a limit, that's about $2,700 in 2009. And they have to get all the way up to nearly $6,000 before the government kicks anything else in. And we've heard from doctors, from nurses, from many of our members that sometimes people either skip medications, they cut pills in half, or they decide just to go off drugs completely. I mean, it's just really something that we think is dangerous for people.
So if you're reliant upon some type of medication that might be expensive, under the prescription Part D plan, you are going to pay $2,700 more than if that donut hole is closed.
Absolutely. Okay. And what the House bill would do is immediately, as soon as the bill's enacted in the very first year, it covers $500 of those costs. And the Congressional Budget Office estimates that over 2 million people will be covered in the first year alone, won't fall into the donut hole. So we know that it will help 2 million people right away.
Right. And we go toward, as you said, closing the donut hole completely by 2019, but there's also, I think, a provision in the bill that also cuts down the cost of what they are paying for the drugs while they're in that donut hole, I think, to half the price.
That's right. There's a discounted price for people that are in the donut hole while we're working to close the donut hole over time, because it is costly, so we can't do it right away. But in the meantime, there will be a discount of 50%. So people who are on brand name drugs will get a discount of 50% as we're reaching that goal of ultimately closing it by 2019, which is something the House bill does for us and the President has guaranteed. And I'm happy to say over on the Senate side, even the Senate leader said that he would be committed to closing the donut hole in the conference bill. So we're really moving forward on this progress for health care reform this year.
You know, I hope our viewers understand how fluid sort of things are right now, in that we have a House bill and we're still waiting to see what the Senate bill does, and then obviously your work and our work will really get started when we try to meld the two bills together and come up with with something that works for both houses and for most of the people. But our earlier guest was Congressman Frank Pallone, who obviously was a leader in this. We talked a little bit about the concern that people in my district have for their fear that this bill will in some way cut their Medicare benefits. And I talked to them about the fact that what we're trying to do is cut out the waste, fraud, and abuse in the system. And simply by doing that, what we are hoping will happen is that we will cut away some of the duplication of services. And Congressman Pallone brought up a personal story of how he would, when his mother was sick, he would take her to the hospital and he would get the same test done over and over again, and it was an invasive procedure, and it was very taxing and costly. And that's some of the things that I think my constituents always like when they hear that that's the kind of duplication that we're going to cut out.
Right. And there are many things like that we think are really common sense solutions that are in the bill. Trying to make sure that we don't pay hospitals for re-hospitalizing people for things that they should have prevented in the first place. No one enjoys going to the hospital, so we're trying to give hospitals incentives to keep people out of the hospital, to come back the second time, to avoid going back, to have transitions, to keep people, give them the right follow-up care so they know what to do once they get out of the hospital, to avoid infections in the hospital, things like that, where we're actually increasing the quality of care rather than rewarding people for just duplicating services or giving them procedures that might not be necessary. So we make sure everybody, all the doctors, have the right information that they need at the right time. And so there really are some common sense solutions in there that we think will increase people's experience when they are in the medical system.
I think you're so right. You know, you hear that all the time now with infection rates the way they are in the hospital. You know, if we can keep a person out of the hospital and still ensure that they're getting the quality of care that they need, it certainly is optimal and something we should strive for. But you know, I learned something else that in talking to different groups. You know, we always think about keeping people at home as long as we can is beneficial to the patient, and I think everyone would agree if we can give them a quality of care at home. It's a good thing. But one of the things that you also see in talking to their families is it improves the quality of life for family members as well, because they don't all have to go up to the hospital or to the skilled care facility. They can be home and have dinner and, you know, still care for the patient at home. And you know, that's one of the things that I think that the bill talks about. And one of the other points, the last point in the last minute here that I'd like you to talk about is, you know, we hear a lot about death panels. Mm-hmm. And you know, that was really troubling to me throughout the debate, because I thought it was clearly untrue. There was nothing about death panels in the bill. Can you tell us a little bit about that?
Sure. It goes exactly back to what you were saying of giving patients the choice to make the decisions that are right for them and their families. And, you know, this was really something that got really blown into the wrong way of describing it in the press, because AARP supported these decisions. It was the ability to sit down and talk to your doctor about these types of decisions and have doctors have the time to sit down with you. How many people talk about, my doctor's always in a hurry, he's in a rush, he doesn't have time to sit down and chat with me. People want to have the ability, just like someone sits down and talks to their lawyer if they want to write up a will or a trust, when they're thinking about their estate or what they want to do after you know, when at the end of their lives, people want to sit down and talk to their doctor about any of their options that they have. And that's all that this was meant to do. Be able to talk with your family. Everybody wants those decisions to be able to get the best advice that they can. Nothing's mandatory about it. It's completely voluntary. And we just thought this was a cruel scare tactic to make people afraid of what was in the bill, and really was an opportunity for people to have the ability to sit down and talk with a professional that they trust and get information that they need. Ultimately, all these decisions are up to consumers, and AARP would never support it if it weren't consumer directed.
Thank you, Nora, for taking the time to discuss the positive impact the Affordable Health Care for America Act will have on our senior citizens. As we have discussed, this legislation will strengthen Medicare for more than 119,000 beneficiaries in New York's 24th Congressional District by including substantial payment and delivery system reforms to ensure affordability and the highest quality of care. That concludes this episode of For Your Information. I would like to thank again our guests, Congressman Frank Pallone and Nora Super of the AARP, for joining me. And thank all of you that have tuned in. I hope this helped explain how healthcare reform might affect you and dispel a lot of the false information floating about what this healthcare legislation will do and not do. And remember, you can always contact me by calling my Utica office at 315-793-8146 or my Washington office at 202-225-3665, or by visiting my website at arcuri.house.gov. Thanks again to all of you that have tuned in. Have a great day.